Okay, good morning. We're going over the presentation for week number 7, and I'm on slide number 6, and I just want to dive in and kind of address the major points that I think should be addressed. So we know that VO2 is a golden standard for cardiorespiratory fitness, with applications to performance or athletic performance and health. It's kind of almost obvious that it's influenced by age, training status, and disease, right? So when we look at the respiratory system, and we talk about the respiratory system, the number one responsibility or function of the system is to buffer the blood. And that's a very important aspect of what we do because it pertains to exercise testing and breathing patterns, and the understanding that at the end of a maximal test, for instance, a very serious part or percentage of the function of the system is to dispose of CO2, which is obviously very dangerous to us, rather than necessarily deliver oxygen first. That, of course, is proven by the pattern of breathing of very fast or high frequency breathing and shallow breaths. If we wanted to be very efficient with supplying oxygen in such a situation, we would have deep breaths and so on and so forth, but that's not what happens at the end of an exercise test. Obviously, the second option is gas exchange. Then we want to humidify the air to allow it to have a higher percentage of water in it, or water vapor in it, to make it go through our system way easier or faster. Of course, we're supplying air, and within that, oxygen. Then we have filtration. We have on the way sections of the innate immune system that helps us with all kinds of particles and viruses and threats from the environment. And of course, we also want to warm the air because it's helping us with all the gradients that we're using within the system. You can see in the next two slides how blood supply is divided at rest and during maximal aerobic ability or capacity. And you can see that by far at maximal capacity, the skeletal muscles are the client, the major client. But notice that it's combined with blood that is circulated to the skin. And then a slide after, basically you have the oxygen supply to the same organs, and it's basically just multiplying maximal O2 saturation by the liters that are of blood that are supplied, and you already know that. We practiced that in lab week. You also know what's on the next slide after that, and that's the idea that we have on one side, on the arterial side of circulation, the whole idea of supply or delivery. Then we have utilization of that oxygen within the tissues. And then we have metabolic buffering and disposal. After buffering is done, we have disposal of non-needed metabolites or outcomes, chemical outcomes of our activity. Afterwards, we have a short kind of schematic idea of the pyruvate junction, whereas we are talking about metabolic pathway utilization, meaning that it's dependent on our extraction capacity and utilization efficiency, right? Which would be give or take dependent on enzyme content. We have the heart that is dealing with delivery, meaning the two major components here are blood volume and saturation. And then we have the lungs that also deal with delivery. In a first stage, they have to oxygenate the blood, and then we have pulmonary capacity and diffusion as two major factors that influence the outcome. Going to slide number 14, we have a schematic of pneumoregulation, meaning the regulation of the of lung or pulmonary function. So if you look at the far upper right part of the slide, we see that we have plasma CO2 concentrations, which are one of the major indicators and triggers of the system. There are others that are being measured, but this one is by far the major one. Changes in CO2 concentrations are picked up by chemoreceptors that send their input to the pneumotaxic brain center, which is in charge of breathing. This center is the only one that is allowed directly to influence our respiratory muscles. Since respiration and pulmonary function are so important to our existence, to our survival, which is one of the major principles that we always talk about, you're not supposed to let anyone influence your respiratory muscles directly and regulate and control their function besides the brain. So this specific center is the only one that is wired, so to speak, neurologically connected to these muscles and is operating them. Of course, the respiratory muscles work more or less according to the orders given by the brain, by the pneumotaxic center, and that causes a change in the disposal of CO2. It either goes up or goes down or stays the same. This change or non-change, lack of change in CO2 disposal is going to affect CO2 in the plasma, and the whole cycle starts again. And this is of course done thousands of times per second or per minute. We see that regulation in total, in general, is based upon two simple ideas or types of information, either mechanical or chemical. Usually the brain wants information from both, and the combination of the picture that is pictured by those two types of information coming from the receptors allow us to regulate either respiratory rate or heart rate. Okay, we can see that chemically heart rate is mainly changed according to O2, and respiratory rate is mainly changed according to CO2. And we can see that although we have baroreceptors, mechanical receptors all over the place in the body, we have two major points. One is the aorta. Changes in the aorta's tension will indicate a change for heart rate, and in the pleural tissue, any changes in that tension will indicate a need for change in respiratory rate. So that's kind of simple. We have the basic idea of respiration. We have to divide it or differentiate between cellular respiration, meaning the aerobic metabolic pathway or the use of oxygen within the cells, and mechanical respiration, which is what the lungs basically do. When we look at the ability to cause air to flow through the system, we have driving forces which are positive forces that help us function, and we have also opposing forces that work against the system, so to speak. And obviously we want the driving forces to be greater than the opposing forces if the outcome that we want is air flowing through the system. So going from left to right, we have the opposing forces. First, we have peripheral resistance, which is the general resistance of a tissue or a system or the environment to the outcome that we want, in this case, airflow. Then we have external pressure on the thorax. For instance, if you have any kind of mass sitting on top of your lungs, the lungs want to expand, right? And that mass is pushing against it. Two examples come to mind. One is fat mass or adipose mass, and the second one would be, for instance, a weight that you can put on your chest when you are exercising in the gym. So for instance, if you're conducting abdominal crunches and you put a weight on your chest, that weight is pushing against the lungs and is basically interfering. Then we have the respiratory muscles as a driving force in active respiration, and we have the elasticity of the lungs as a driving force in passive or non-active breathing, meaning breathing that does not need the respiratory muscles and does not demand energy investment or minimal energy investment. So how do we influence the pleural elasticity? Obviously, we're talking about what would cause changes or adaptations to exercise. So we have the mechanical stimulus. As you well know, without a stimulus, you're not going to get a response. That's one of the major principles we always talk about. So, we'll constantly measure the lungs tension. We can measure muscle activity, right? That's going to influence sensors that indicate that an adaptation is needed. In addition, you can also change the content of the tissue itself. So that can be by increasing or decreasing the water content of a tissue, and of course elastin fibers. And that will, and those two changes are going to allow for neurorespiratory regulation. So, in the next slides 20 and 21, I think that if you go over it, it's kind of simple. I don't think it needs much explanation. Basically, it's what happens to oxygen within the air from the minute that it enters from the environment into the body, and you should know that by now, and if you have any questions, just let me know. So we can jump to slide 23, and we're looking at aerobics. In this case, I mean the ability to conduct air through the system, and of course generate energy by oxygen, so basically both kinds of respirations. So we see that your aerobic ability has indications of functionality, right? And it can also indicate any clinical problems. So when we're looking at the functional aspect of things, we're talking about the ability to supply, the ability to utilize, and the efficiency of the utilization. So the assumption that you're utilizing 100% of what is supplied, at least in humans, is definitely a mistake. When we're looking at clinical populations, we're talking about any pathologies. We're talking about the ability or the influences of rehab on those abilities. And of course, we can also tie it into research. So in the next slide, we can see that the clinical aspect has changed a bit, and we're talking about the cardiorespiratory anatomical supersystem as the major influencer of the ability to supply oxygen. We see that the utilization is at the level of the skeletal muscles, which is not a new idea. And we can see that the efficiency is influenced mainly by enzymatic ability, concentration, and efficiency. If we're looking to see how the efficiency of and the capacity of the system is reduced, we have to address two kinds or types of volumes, which are called dead spaces. In this case, they are called dead spaces because in physiology, if it's not contributing to metabolism, it's not interesting. I mean, it's interesting, but it's not contributing to life, to being alive, to surviving, to producing energy, right? So we have the anatomical dead space, which is caused due to anatomical structure here in the trachea, and because of cartilage that we have in that area, which has pores in it, air is caught in those pores and does not reach the alveoli. If it does not reach the alveoli, it's not exchanged and is not diffusing into the blood. It does not reach the metabolic pathway, the aerobic metabolic pathway, and we can't use it. So that's the anatomical dead space, and that's about 30% of tidal volume. So out of 500 milliliters, which is half a liter, about 150 milliliters are lost in that part. So basically, in a normal person, not a diseased person, or a deconditioned person, the system's capacity or efficiency starts at 70%, which is already very low. And from there, it's going to get even lower, right? And then we have physiological dead space. Physiological dead space can be caused by many diseases that will affect, for some reason, the volume of air that reaches the alveoli or that is exchanged between the alveoli, meaning the lungs, and our blood stream or blood circulation. So you have in the next slides pictures showing you the respiratory system with the trachea going into 3D pictures of the alveoli with the outer and inner side, and then you can see the trachea with the cartilage rings around it. It is at this place that the anatomical dead space is produced. You can then see kind of a cross-sectional picture of cartilage with the pores and the explanation about the dead space. Alright, in order to understand respiratory abilities, we need to understand that gas diffuses through the barriers or the membrane, so to speak, from the respiratory system end, margin, being in this case the alveoli, into the plasma, right? So in this case, the diffusion depends on certain factors or components that are addressed here in this slide, and we can see that V, which is the transition of velocity, meaning the time or the speed, distance per time that a molecule of oxygen will diffuse from the alveoli into the bloodstream is. Notice that this does not talk about the percentage of diffusion, the amounts of perfusion, the pressure, and so on and so forth. Or it does not indicate saturation at the end, right? So it's just how fast is this molecule going to move from one end to the other. And you can see that it depends on a parameter called T, which is the thickness of the membrane or the barrier. This is logical, right? The thicker the wall or the area where you have to enter through, the more time it's going to take you. Then you have A, which is the diffusion area, meaning how many doors, how many areas are you allowed to diffuse through. So let's say that you want to enter a building and the building has only one entrance, but there's 1,000 people trying to enter at the same time. That would obviously take more time than if the same building had 4 doors or entrances and now 1,000 people are trying to enter, and suddenly you have 100 doors. So the more, the bigger the area that oxygen can diffuse through, the faster it's going to happen, most likely. And then you have what we call the diffusion coefficient, meaning how great is the tendency of this gas to diffuse. So that would depend on factors such as size, movement ability, electrical charge, and so on and so forth. And then we have the pressures. The pressures, the partial pressures of the gas between 2 points, and we'll address that in a second, are what is causing the gradient, right? And we talked about the gradient, and we know that if the differences between 2 points is 0, basically the gradient is 0 and you're going to have 0 movement. So we'll see how pressures or partial pressures specific to a certain gas cause it to move in the direction that we want it to move. In this case, we want it to move from the lungs, from the alveoli, into the plasma circulation. And you can see at the bottom of the page the relationships between certain factors or components of the formula. Okay, so we just talked about the influencing factors. I won't go over it again, it's kind of spoken for. We're talking also about, for instance, the relationship between blood flow and the delivery of O2 and disposal of CO2. Obviously, we want it to be in a linear relationship between the two. Any changes to one of those factors that we've just talked about would definitely change our ability to have oxygen diffuse or CO2 diffuse going the other way. By the way, oxygen and CO2 are always going in opposite directions, just so you know. When one is supplied, the other is disposed. And of course, this is going to influence oxygen delivery and aerobic capacity. Alright, so kind of a bit about gas exchange, and we are on slide number 35. We can see that we have 2 gas exchange areas in the whole procedure, and this is kind of basic knowledge. I hope you know it, so I'll go over it really fast. When we're talking about CO2 disposal, in the first area between the lungs and the pulmonary circulation area, we want CO2 to leave the blood and enter the lungs so we can expel it through our respiratory system, meaning the nose and the mouth, of course. O2 we want to deliver, meaning we want it to leave the lungs and enter the blood. In the second exchange area, well, it depends on the circle, on the circulation where you're starting at, but if we started at the lungs, so in the second exchange area of gas, we have this exchange between the tissues. In this case, we're representing those tissues by the muscles because they are the major client during exercise, and the plasma circulation or blood circulation. So we want CO2 to leave the muscles and enter the blood so we can dispose of it to the lungs, and we want CO2 to leave the blood and enter the muscle so the muscle can utilize it. How is that done? So we utilize a pressure gradient. Remember that if we want something to move, it's going to move from the higher value to the lower value. I'm going to say that again. It's going to move from an area with higher pressure to lower pressure. Exactly like water runs from higher grounds to lower grounds, right? And not vice versa if we're talking about a passive gradient, and this is definitely a passive gradient. So analyzing in the upper half of the table on the next slide, we see the first exchange area between the lungs and the blood. We can see that in the lungs, the partial pressure of oxygen is 105 millimeters of mercury, and in the blood it's 40. Since gas is going to move from a higher pressure to a lower pressure, oxygen is going to move from the lungs into the blood. Then we see that the partial pressure in the blood for CO2 is 46, and in the lungs it's 40, so it's going to move from higher to lower, meaning from the blood to the lungs, and this is exactly what we want, right? If the numbers were switched, we would suffocate and die extremely fastly. Then we have the second exchange area, as we said, between the muscles in this case, or the body's tissues, it doesn't really matter, and the blood. We can see that we're losing a bit of our power, of our driving power in the bloodstream. So oxygen partial pressure goes down from 105 to 100. But in the muscle, the partial pressure is still 40. So oxygen is going to move from the higher pressure to the lower, meaning it's going to leave the blood stream into the muscle. And we want CO2 going over to the other, in the other direction, in the opposite direction. So we see that the partial pressure in the muscle is 46, and in the blood it goes down to 40, because we have disposed of CO2 through the lungs and lose partial pressure in there. And of course, in this case, CO2 leaves the muscle and goes into the bloodstream, which is exactly what we want. Any changes in those numbers, are for better or for worse, are going to change the gradient, and that might result in a change of direction of the process and at its extent. So the bigger the gap between 2 points, right, the values, the faster and more extensive the process is. So we can see that in the transition from rest to maximal effort, the content of the alveoli is tripled, and the same goes for the amount of capillaries that are available, or what we call open, for gas exchange. That pertains, of course, both to the pressure that is generated in the system, and the diffusion area of the system. Okay, we can see that oxygen saturation can go down due to extraction up to or down to 10% in well-trained aerobically athletes, meaning that they are utilizing or extracting a very high percentage of oxygen from the blood. Okay, we can see when we talk about delivery and extraction that there are many other processes in the middle and factors that would affect oxygen saturation and oxygen extraction. We know that CO2 and O2 compete over a seat, a place, so to speak, in the hemoglobin protein, and they're kind of completing each other, complementing each other in percentage. The more oxygen that is released, the more CO2 that is attached to hemoglobin, and we're actually using the same protein in a way, carrier in a way, both to deliver O2 and dispose of CO2, which is very efficient. We can also see that the amount of 2,3-DPG and the environment acidity is going to affect the hemoglobin protein and its tendency, affinity to oxygen or CO2. This is what we call the Bohr effect. And we can see that there are changes throughout time, pressure, and pH on the tendency of hemoglobin to be attached to this or that gas. As we've seen in prior presentations, the ability to extract anything from the plasma depends also on blood flow velocity. The faster blood flow is, the harder it is to extract gases and anything from the blood. In addition, partial pressure is going to be a factor here, as we talked about gradients, capillary count, the amount of avenues, so to speak, or what we call the diffused area, the contact area with the neighboring tissue is equivalent, as I've used a certain idea, to the number of doors into a certain place, right? Of course, within the muscles we have myoglobin, so the concentration and the efficiency of myoglobin is going to affect the ability to receive what is coming into the tissue. And of course, then we have utilization, which depends on the metabolic pathways and all the characteristics of a metabolic pathway. But I think that the major one, not the only one, by the way, the major one would be, of course, the enzymatic concentration. Okay, we see that, and this is from my PhD, we can see that we have, to the Fick equation, we have three major components. If you break it down, you have stroke volume and heart rate, which are the two components that result in cardiac output. And then we have A minus V differences, which is an indication of the ability to extract oxygen. And we can see how, in this case, in 6 different populations, the first one being adolescents, and then we have young trained men, then we have untrained advanced age adults, and we have the same age adults only trained, we have CAD patients, and then heart transplant patients. We can see how VO2 is established or accomplished, and what is the major factor component that allows that. And we can see that definitely when delivery is at risk, the body has to adapt or fail. So adaptation first, if not death. So when gas exchange is 0, obviously you're dead. And it seems kind of simple, but we often forget about it. So we need gas exchange to be more than 0, and obviously it's also a relative 0. So there's a certain level of gas exchange that we need to achieve within the system in order to deliver and supply the minimum needed to exist and survive. Okay, we are at slide 42 and talking about pulmonary adaptation, and of course we're just refreshing your memory, so we're going to go over it kind of really quick. When we talk about changes in respiratory indices due to exercise, some of them are given and some might be needed to be explained. So we can see in the table that we see on the left column the variable and then what happens due to exercise at rest. Just a reminder that you should know, and as clinical exercise physiologists, that rest means 0 intensity, right? And then we have what happens at submaximal effort and then at maximal effort. So we see that VE, minute ventilation, at rest, there's no change. There's no need for change because we are at 0 intensity. So the overall need for air supply or oxygen supply does not change. And of course we know that with exercise going from rest to maximal effort from 0 to 100 percentage of intensity, it increases. We see that due to exercise we have an increase in volume according to the principle or the rule of adaptation, that volume and efficiency first and rate after. So VT increases at rest, submaximal effort, and maximal effort. Accordingly, if you have an increase in volume, you are allowed to decrease your rate or your pace. So we see that respiratory rate is decreased at all levels. Then we have pleural elasticity. We see that there's no need for change at rest. We are not really utilizing the change in elasticity at rest, which can be conducted passively, but we do see that we need to utilize the changes to the pleural tissue and its elasticity during submaximal and maximal effort. Then we have resistance. We want resistance to decrease, and we see that peripheral resistance is decreased at submaximal and maximal levels. The next slide shouldn't even be here. That's weird. We see that the one after that is a slide that kind of indicates the most influential factors on pleural indices, and I think that this is kind of straightforward. Obviously, when we're talking about VE, VT and RR are the major components, with VT definitely leading. And then if we're talking about active respiration, then the respiratory muscles work kicks in. When we're talking about VT, size, obviously, or volume is a major indicator. And then the pressure gradient that allows, oxygen to enter or air to enter the lungs. Then we have the time that we are given to fill out the lungs, so inhalation length, and then also the help of the muscles. When we're talking about RR, we're talking about the impulse velocity as a major indicator of maximal ability. Then we have, of course, volume, plasma CO2 levels that we've talked about, regulation, and also lactate, which in this case is an indicator of what's going on in the muscles. When we're talking about pleural elasticity, I put in first place smoking. I think that it's important to put it in here, although it's not exactly a natural physiological component or factor. I wanted to emphasize how smoking affects the lungs, and obviously it's going to affect pleural elasticity to a great extent. We've also talked, or will talk about that in pathophysiology. After that, we see that aerobic fitness is the #1 factor for changing the content of the tissue. And once again, we have the respiratory muscle work, because elasticity does respond to stimulation, in this case mechanical stimulation. We see in peripheral resistance that air temperature is very important in order to help the air slide or go through the system. Trachea diameter, obviously, you have a tube. The diameter of the tube is very important to the amount of air that can flow through it, and there is a exponential relationship between the diameter and the resistance. Air humidity, as I've spoken, the more wet the air is, it slides through the system faster. And of course, we've seen that the anatomical structure, and we know that as a principle, is going to affect resistance. So we saw, for instance, the anatomical dead space. All right. Then we have in slide 46, about 1/3 of the way in, we are starting the topic of spirometry. So I would like to stop here, and we'll talk about spirometry in the second video to be uploaded following this first video. Stay tuned.